Good afternoon, and a very welcome to all of you joining the webinar today. My name is Dr. Gerard Ross, and I'm one of the medical legal advisors, and I run the Scottish team in the MDU. Prior to joining the MDU, I was a consultant surgeon in Scotland as well. Joining me today is my colleague, Dr. Ed Farnan, who is now a medical legal advisor in the MDU, but prior to that was a GP partner in Northern Ireland, and as well placed therefore to talk about complaints in Northern Ireland. We're going to spend the next little while talking about good practice in complaint handling and where you can turn to for support. And I'd like to point out that we are recording this and it's going to be made available for people to watch on demand, just in case you've had your fill of Netflix and you want to see this again. You can do that. This is the first of the year's webinars. We have a series planned of them, and there's some really important ones coming up, moving into areas we don't often talk about, so that's quite exciting in terms of development. Do remember that you can submit your questions through the questions box in the drop down. Please do put some questions there. We're happy to address them, but try and keep them as short and concise as possible, because when they're long and discursive, they're quite hard for us to answer. You'll be sent a certificate of attendance at the shortly after the webinar, or at least within the first week. We are going to swap over as we're talking between Ed and I, as long as I remember to do that. So Ed will no doubt drop in. So we know that the complaints are a difficult topic, and we see problems for doctors all the time when complaints aren't handled well. And I think one of the things that I'm very conscious of, and I'm sure Ed would agree, as I hope he would, is that sometimes there are some complainants who you're just not going to make happy. However, things are really difficult now because we're seeing exhausted doctors, patients who hear nothing good about the health service. It's always negative news about access to care and about the treatment that people are receiving. And I think that doctors are reaching the end of their tether, and complaints on top of that can make things, horrible for staff members, not just the doctors, of course, also the practice managers and the receptionists. So most of this webinar is going to cover some of the basics about complaints and give you some ideas about how we think it would be helpful if you tackled complaints when they come up. I do know that some of you are going to have additional responsibility for the operations of the complaints processes where you work, and we're going to talk about that as well. So the specific issues that are going to come up are frequency, the impacts, the importance of it, how we recognize it, acknowledging, investigating, how to respond, and using that response in a way to set the playing field and to make sure that the practice looks good. If the complaint is looked at by another body, be it the Northern Ireland Public Service Ombudsman or the SPSO in Scotland, or even the GMC, the practice and the doctors involved, look like they've managed in a professional way. And things to think about if it's not resolved with the initial meeting. In terms of Scotland, the majority of complaints are to territorial boards rather than to the contractors. But so of that 35,000, only 7,356 in 21-22 went to the GP contractors. A much smaller percentage, which fits with the number of health board practices, went to health board practices. It's about 6.3 complaints per 1,000 people, which is actually surprisingly higher than in England. We often think of Scotland as an area where complaints are less frequent, but in reality, at least in this 1 year, complaints were higher in Scotland. The devil will be in the details of those, and of course complaints are compiled in different ways and in the different countries of the UK and Northern Ireland. Speaking of Northern Ireland, I'm going to hand over to Ed now.
Thanks, Gerard. And I suppose that the key point to just to tease out here at the very start is that while the administration of complaints is different across the two jurisdictions and indeed from the rest of the UK, the general principles of complaints handling are the same wherever you're working. But so we're going to look maybe at complaints handling in general, but also a little bit about the specifics of how complaints processes are administered in each jurisdiction. Starting with Northern Ireland, these are the most recent figures which we have published by the Northern Ireland Department of Health. They're for the 2021 year. And I think it's worth saying that while this talk is really focusing on complaints, it's striking that many more compliments than complaints were received in the relevant period, and most of these compliments related to the quality and treatment of care. Now, I would emphasize that this is probably a slightly unusual year. This was the 2021 year when things were at the height of the pandemic. I think things that people might have complained about or offered compliments about might be different within that year. So these figures come with a slight health warning. But you'll see that really in terms of the published figures, there's a very small number of complaints about general practice, and the complaints regulations and the GP contract regulations both require practices to inform the Health Board of the number of complaints that they have received, as well as the subject matter about those complaints. And in Northern Ireland, in that year, the number of complaints relating to general practice which were notified to the Department of Health and to the Health Board in those days was lower than in any of the preceding 4 years. About a third of them related to treatment and care, and a quarter to communication and information or to staff attitude. And about 90% of those complaints were dealt with at practice level with the Health and Social Care Board, as it was then known, assisting in a small number in their role as an honest broker. And that honest broker role is quite specific to the Northern Ireland regulations. Now, if I can unleash my inner Chris Whitty and ask Gerard to move on to the next slide.
I'm going to just interject slightly as well, say that where the next slide, Ed, is are the English figures in terms of what complaints are about. I'll let you carry on.
Yeah, I was going to say we have some data about what complaints were about for Northern Ireland. We don't have similar data for Scotland. So these are the English figures published by NHS Digital. And if you're terribly interested in this, NHS Digital website gives you a much more detailed breakdown about this. But you'll see here again that by and large, the most common reason for somebody to complain was relating to the actual clinical treatment. But a significant number, similar to Northern Ireland, give or take a quarter of all complaints related to communication or attitude and behaviour as perceived by the patient. So moving on.
I guess the important point on that, Ed, is that that's something that, you know, there's some agency in from the practice and an opportunity to try and head off at the pass in some circumstances when clinical complaints are often more difficult because of the uncertainty, I guess, within general practice that is just dealt with on a day-to-day basis.
Absolutely. I mean, I think communication is key to most of general practice. GPs spend an awful lot of time training in terms of their communication skills, but it's important also that those skills and that training is disseminated to members of the team, and that can head off a lot of problems before they become a problem.
Sure.
Moving on, this next slide just illustrates what I think we all know is that complaints are stressful for everybody. They're stressful for the patient. I think we have to acknowledge that nobody wants to be in a position where they're having to make a complaint about their healthcare, because at least in the mind of the patient, rightly or wrongly, it's a sign that something has gone wrong. Certainly in the mind of the doctor or the clinician being complained about, it's stressful, it's time consuming, it will often result in frustration, in sleepless nights. It's not where any of us want to be. And if you're the doctor in a practice who's responsible for managing the complaints process, if you're the complaints lead, the responsible person, it's stressful for you as well, because you're having to look into one of your colleagues' clinical practices or something that's gone wrong within their day-to-day work. And it's an uncomfortable position, I think, for everybody to be in. But particularly for doctors, there's a thing which we know as multiple jeopardy. And this gives us sort of an illustration of how that can happen, whereby a single clinical incident, let's take for the sake of argument a prescribing error, can result in the red box there, a complaint made under the NHS complaints procedure. but it can result in far more than that, depending on what the outcome or the perceived outcome was for the patient. It can result in a civil claim made in negligence. It can, in extreme cases, result in a criminal investigation if things have gone badly wrong. It could trigger a disciplinary investigation, particularly if it's felt to represent a pattern of behaviour. Patients, as we all know, can complain to the GMC either at the end of a complaints process locally or as a first line of attack. If the outcome for the patient was that they died, it can trigger in Scotland a fatal accident inquiry, or in Northern Ireland and elsewhere in the UK, it can trigger a coroner's investigation. And really what we also see at the MDU is it can trigger interest in the media. If patients go to the press, that can prompt very difficult questions for the practice from the press. And while it's unusual, I have to say, for all of these arms to be triggered by a single clinical incident, it's very common, I'm sure Jared would agree, for 3 or 4 of them to be triggered by a single clinical incident. And that,
I mean, just on this slide, there are some differences between the jurisdictions, Ed, sorry to interject, which is one of the benefits of practice in Scotland is that criminal investigations are actually much rarer in Scottish practice than they are certainly in England and Wales, where they are still rare, but more common, certainly by comparison. And FAIs are actually relatively uncommon. There's about 40 a year involving medical care, unlike coroner's cases, which are thousands of cases in any one year. Just to demonstrate a little bit of difference between those jurisdictions.
Yeah, and coroners, my experience certainly of coroners investigations in Northern Ireland is that we seem to be getting requests for advice and assistance with more than we previously did. Whether that's because people are more anxious about the process or whether that's because coroners are just becoming more active, it's hard to say. But moving on, just to the next slide, just highlighting that there is an obligation on all healthcare professionals, in particular to doctors. The GMC requires that doctors cooperate with formal inquiries and with complaints procedures. And we've highlighted there that the 2 jurisdictions, Northern Ireland and Scotland, have particular legislation which governs the complaints procedures. And we're going to talk a bit more about the differences in terms of timeframes for providing a response and the like. And the reason that there are differences is because the specific legislation in each jurisdiction differs slightly. So if I can hand back to Jared at this stage to talk a little bit about the Scottish specific information.
Thanks very much for that. And just to highlight here, one of the things that I notice when I'm dealing with complaints with doctors is that there's sometimes a reluctance for other staff to become involved because they don't feel the same obligation. But remember, of course, that nurses and other allied health professionals have a much bigger role in healthcare provision and primary care across the UK and Northern Ireland now. And nurses also have an obligation to engage with complaints. It's, the NMC are clear on that as well. So it's not just doctors. I think sometimes other allied health professionals and nurses are slightly less keen to engage and do that reflection that we all think is important and relevant. Coming on to the key features, we don't need to go through the Act, and in fact I don't intend to, but the Patients' Rights Scotland Act is what the relevant legislation is. There's a very helpful document from the guidance from the government called Can I Help You, which talks through the regulations, and I would encourage people to look at that and the model complaint handling process which will also come on to tidy up the responses that they're putting out to complaints. We're not going to focus on the specifics, as I said, but basically you've got 3 different parts to it. You've got the early resolution, the on-the-spot apology, explanation or other action to resolve a complaint quickly in 5 working days or less. There are exceptional circumstances that let you put out to 10 days, but it shouldn't be normal to extend it to 10 days. So complaints addressed by any member of staff or alternatively referred to appropriate point for early resolution. That's what that one is. It's still important, I think, to keep a record of the complaints and the action taken for service improvement. Then you've got the investigation stage for those that can't be resolved in that early resolution process. You've got 20 days to look at the complaint and to write a response. Again, it can be extended in restricted circumstances if you just can't manage a response in that time. So this is a point of contrast with the process in England, where it's not in any way restricted, and other than the fact you've got to have a reasonable response time. So we often give ourselves, there's quite a tight timescale for dealing with quite complicated matters. I think the important thing here is if you can't manage it, which is not surprising in certain complaints, it's important that there's some communication going on with the complainant about the difficulties, the challenges faced by the practice in managing the problem. Remember as well that responses have to be signed off by senior management within the practice. And the final stage would be that independent external review, which is the role of the ombudsman. And hopefully that's not something that you will have to face all that frequently. So two-stage process, that local resolution with either early resolution or the investigation, and then the SPSO involvement applies to all bodies and providers of NHS care. One of the difficulties is when you have a complaint that is both about a health board provided service, so the local hospital, and the complaint address, it also involves aspects of care provided in the general practice. Not at all unusual. In that circumstances, both organisations have to cooperate. That's in the regulations, and one should take the lead. And normally, it would fall to the organisation which has the majority of the care provided, and that will obviously depend on the circumstances. Complaints should be brought within 6 months of the event, or 6 months of the patient becoming aware of the issue, but not normally more than 12 months after. And what these are guidelines that are out there and requirements that are out there. But what I would say is that doctors and practices should be flexible in their approach to that, because remember that the next stage for the practice might involve the SPSO becoming involved, or for a doctor it might involve the issue going to the GMC. So if something comes in late, but you think that there are things in here that we could have done differently, we might have been able to improve, then act on that. Don't just turn to the timelines and say, I'm sorry, you're out of time, because the next review of the complaint will have different timescales and might be much more stressful both for the practice and for the professionals within the team. You've got to have a well-publicised written complaints procedure. Should be advertised in the practice and easily available. It should be something that is on your website, and there has to be an effective investigation process in place. And as you know, you have to report back about your complaints data. So what should you do when you get a complaint? Well, you've got to acknowledge it within the 3 working days of receipt, and the acknowledgement has to contain certain things. Again, it's set out in the good complaint handling, the model complaint handling process, and the guidance I referred to from the Scottish Government. Contact details for the feedback and complaints officer for the practice, details of advice and support, including PASSS. Mention of the SPSO, the Public Services Ombudsman, and a statement confirming the complaint will be investigated within 20 days. So there are a number of things that are expected from your acknowledgement. We're going to talk a little bit more about the opportunities that the acknowledgement gives you and that you should grasp in a few more slides, but those are things that must be in. You then got to conduct a thorough investigation and provide the complainant with a written response. Ed, are the regulations in Northern Ireland, are they quite similar?
They're similar and different is the way I would describe that. So if you want to sort of look at the basics, it's similar in the sense that there is a two-stage process. So there is this concept of local resolution, which is resolution of the complaint at practice level. And then there's the second tier, which is escalation to the Ombudsman, which in Northern Ireland is the Northern Ireland Public Services Ombudsman. And that applies to all health and social care bodies in Northern Ireland. So moving on to the next slide, much like in Scotland, if there is a situation where there's a complaint about two different bodies, whether that's two different GP practices or primary care and secondary care, there is an expectation that the different bodies will cooperate in order to provide a coordinated response, with one organisation ideally taking the lead. There's a similar time frame for when complaints should be brought, again within 6 months of the event or 6 months of the patient becoming aware. But again, I would suggest that you try and adopt that one fairly flexibly. As Jared says, if with hindsight you think things could have been done differently, this is the opportunity to address that if you can. Similarly, if a complaint comes in late and you're satisfied that you couldn't have done anything differently, the clinical care and everything that was done was appropriate and was of a high standard, falling back on the time frames to say you're too late to make a complaint is only going to cause a degree of confrontation, whereas in fact a response to that actually will be able to present you in a good light. Jared mentioned the fact that the time frames in Scotland are quite tight. In Northern Ireland, in primary care, they're even tighter. The complaints regulations require that a response is sent within 10 working days. And really, for everything other than the most straightforward of complaints about minor matters, that's really not sufficient. What's important in that situation is if you can't respond within that 10-day period, it's important to keep the complainant updated as to the progress of your investigation and as to when they might be able to receive a response. So moving on to the next slide, again, there's an acknowledgement which must be sent, and we'll talk a bit more about acknowledgements shortly, but specifically in Northern Ireland, as part of that acknowledgement, you're required to make the patient aware of their right to seek assistance from the Patient and Client Council, which is a statutory body established for that type of purpose. Have a discussion with the complainant at the outset so that the matters being complained about are clearly identified and understood by both sides. If you are going to breach that 10-day time, make sure that you keep the patient informed. And the next slide sort of highlights the guidance which is available from the Department of Health on the 8 standards which they expect to be adhered to. So it's fairly clear what those are. Accountability, which is in terms of the procedures and ensuring that the relevant directions are complied with. In other words, that you do things within those time frames or explain when you can't. Making sure that complaints procedures are open and easily accessed by patients and their representatives. That when you receive complaints, you try and make sure that they are all dealt with seriously, but also with courtesy and in a timely manner, and that you will respect confidentiality. Ensuring that support is available. So for patients, that's ensuring that they are aware that the Patient and Client Council is available, but also ensuring that the staff members who will be dealing with complaints are appropriately trained, that you make appropriate use of conciliation, and that you take advice from either lay persons or medical people who can advise on the care that was provided. That investigations should be conducted promptly, but also thoroughly, openly and objectively. That for practicable, time frames are met and all aspects of the complaint are addressed. So it's no good responding to one point, but not responding to the other 4. Monitoring really is involved, is a situation whereby you're supposed to keep the department or the board aware of the numbers of complaints that you've received and the subject matters. And then learning, which is important both within the terms of the NHS complaints process, but learning from complaints and reflecting on them is also an important part of the appraisal and revalidation process for all clinicians. So that's sort of the Northern Ireland aspect in a nutshell. Back to Jared just to talk a bit more about how to manage a complaint. And before we do that, just a reminder that if you do have any questions, please feel free to submit those in the question section on the webinar tool.
So the first part of managing a complaint is recognizing it as a complaint. And one of the things that we see frequently being done is people giving feedback or actually complaining verbally and being told, we'll go and put it in writing. And of course, I'm going to supply the answer here rather than polling, and I'm sure you all know it. All formal complaints do not have to be in writing. People can complain verbally and frequently do complain verbally. In terms of the Scottish model complaint handling process, which came out from the SPSO in 2017, was updated in 2021, a complaint is an expression of dissatisfaction by one or more members of the public about the organisation's action or lack of action, or about a standard or service provided by or on behalf of the organisation. Importantly, and again differently from other parts of the United Kingdom, there are some exclusions in Scotland that often people are not aware of. There's a whole list of them, in fact, but specifically things that have where legal proceedings have actually started, as in solicitors have been instructed, the complaint immediately falls away. In England, that's not the case. You can have both a complaint and a claim running simultaneously, which is awkward. Similarly, a complaint that has gone to the Ombudsman, or the Ombudsman's already involved, the practice are stop being involved. Slightly awkwardly in the Scottish process, we've got other ways of people feeding back. We've got feedback, so forms expressed views expressed on a form for the practice and a patient questionnaire. We've got comments, and that feeds into the compliments thing as well, but comments about the care that's being provided to them are also mentioned in this modelling complaint handling process. And we've got concerns which can be expressed about care they've received. So it's a bit confusing because there's complaints and then there's these three other categories. And I think the point is that all of these other categories, concerns, comments, and feedback, can actually be complaints if they're fed back in a particular way. If they're fed back in a way that suggests the patient has suffered or feels that things could have been done better for them, or feels let down, then I think the practice should consider all of those things potentially as sources of complaints. In Northern Ireland, it's a slightly different definition. Ed, do you want to just quickly talk through that?
Yeah, again, I would sort of emphasise that the same thing applies in Northern Ireland as applies in Scotland, which is to say that there are some things which automatically become excluded from the NHS complaint process, including if a complaint has given rise to a referral to a regulator, such as the GMC, or if a complaint is the same matter is subject to sort of litigation. So if a patient's making a claim, then the complaints process does not run in parallel as it would in England. The other definition within some of the other guidance published by the department is that it's any expression of dissatisfaction that requires a response. And the legislation in Northern Ireland specifically says that complaints can be made orally as well as in writing or electronically. And if a complaint is made orally, obviously if a complaint is made in writing, you've got the written account of that automatically. If a complaint is made orally, the staff member who receives the complaint should make a written record of that, including the name of the complainant, the subject matter, the date at which it's made, and so on, and then provide a copy of that to the complainant so that there's a clear understanding about what the issues are that you're going to be addressing.
We also have in Scotland, I've kind of I've shown it in the slide, that we have this, how we deal with minor niggles, this things that can be resolved on the spot. A verbal complaint that can be resolved to the satisfaction of the complainant within 5 days is excluded from the formal arrangements. And it kind of feeds into what Ed said on that last slide about the importance of the interaction of frontline staff with complainants, with people when they come in. People need to be trained and empowered to respond positively and appropriately to feedback and or verbal complaints. And it's really important that we don't throw away serious feedback, even if it can be resolved. Serious issues being brought up that might impact on patient safety need to be considered by the organisation, even if the person has been satisfied with the response. And in that circumstance, if there's a patient safety issue, even if the person goes away satisfied with the verbal complaint, there's still an obligation, I think, in that circumstance for the practice to really take on and put that down the formal process line. Even if the person's gone away happy, if the practice are concerned that this is a patient safety issue we should really have picked up, then dealing with that appropriately is relevant. Ed, I don't think you've got the minor niggles thing in part of in the regulations, really, have you?
Actually, it's not part of the regulations. There is some relatively helpful guidance from the Department of Health, which says that essentially complaints which can be dealt with at the time that they're received by the person receiving it. So if a patient complains that their prescription wasn't ready, if that can be resolved there and then by a member of staff finding it and delivering it to them, then that doesn't have to be dealt with through the formal process. So that it's not part of the formal part of the regulations, but there is some generally helpful guidance along those lines that minor niggles, which can be resolved promptly at the time, might not need to be dealt with through the process.
Cool. So I think, Ed, if you just take over from here.
Yeah, so I mean, this is the sort of complaint that we see, certainly not infrequently. So it's a patient who describes having been discharged from hospital after having had an operation. They've had a stoma. Obviously, within their mind, this raises queries. They think back to a previous consultation where they'd seen a doctor. They wonder if they had been seen more promptly or had been referred more promptly, they might not be in the position that they now find themselves in. They've also got some concerns about difficulties that they've had with the stoma since they've had it, and also issues about the prescription that they feel they need and how they interacted with the receptionist. So moving on then to the next slide.
In terms of and I was going to say about acknowledgement, what I said earlier on about the value of the acknowledgement is in the opportunity it gives to the practice to get things start the process of getting things right. And we often see acknowledgements along this sort of line. We're sorry you felt the need to complain. We'll respond to your concerns within 10 days or 20 days. And it's helpful to compare that with something like this. I'm sorry to hear about your diagnosis of bowel cancer and your concern that your treatment was delayed. I understand your main concern was that you should have been referred to a hospital sooner. So I'm making it clear to the patient that you understand what their issues are. And of course, if you don't understand from the complaint what the issues are, it's really important that you go and find out specifically. Patients are often worried that they're not going to get care because of putting a complaint in. This is something that is frequently voiced. And of course, we all know that that's not the case, that they will continue to be looked after. A complaint will not affect the care, but actually saying so is often quite a good way of reducing anxiety. Setting out what you plan to do about the complaint, giving them a direct contact number, and so they can let you know if there's other people that they feel that you should be engaging with, and telling them when they should expect to get a response by is always a worthwhile thing to do, and updating them that you will let them know if there's going to be a problem with that. And it's also a good opportunity to sort out issues about consent. So let's imagine you've got a complaint about the care provided to an elderly relative. The complaint's coming from the daughter or son of the patient. You may need to think about consent. Well, you almost certainly will need to think about consent to address it. Similarly, if you've got a parent complaining about the care provided to a child, and that child is over the age of 12 in Scotland, Gaelic competent in Northern Ireland, then you may need to think about checking with the child that you want, they would want you to respond to the complaint to their parents. So acknowledgement is an opportunity to set out what's going to be investigated, to talk about consent and to manage expectations, and also to set out who the feedback officer is, the patient advisory service, the SPSO details as is required. Ed, I involved you early. I messed up the slides, so I'm going to let you take back over now. Apologies.
That's fine. So yeah, what we're looking at now is really how to investigate a complaint. So if we have another look at that letter that George was, we've highlighted a little bit of it here. So what you want to do when you receive a letter of complaint is to go through it very carefully. You'll probably scan it in the first instance and you'll identify the key point or points. But what you don't want to do is to miss something important that the patient thinks is important, but might be hidden somewhere within the letter. So it's important to go through a letter, really go through it line by line, perhaps with a highlighter pen, perhaps with a red pen to underline the things that you think you need to do or need to act on or need to address. So you want to sort of pick out the key points that the patient is raising concerns about. Key points here are that they've recently had a diagnosis of bowel cancer and they think that they weren't referred sufficiently urgently. They're struggling, there's a problem with the repeat prescriptions. So they're asking questions there in the first part of that about the doctor, but in the second part they're asking questions in terms of the repeat prescriptions, about the way that they interacted with the receptionist and how they dealt with things. So moving on to the next slide, by going through that letter the way you have done, you know that what you're going to have to do to investigate this is to firstly take an account from the receptionist, because they're involved in the issue about repeat prescriptions and availability of emergency appointments and how those were booked. You want to take an account from the doctor who was concerned about what they did, what their management plan was when they saw the patient initially, when the patient thinks that they should have been referred. And then you're going to want to undertake some form of review of the actual clinical management that took place. Certainly reflections from the doctor. What did they do? Why did they do it? If they think something might have been done differently with the benefit of hindsight, what would that be? Discuss the case often within the context of something like a formal practice review, a significant event meeting, preferably if you can have somebody independent of the clinical care that was provided, perhaps a senior partner in the practice, a colleague in the practice who's likely to be able to view things objectively, to sort of review what did happen and also review, for want of a better word, what should have happened. And then sort of moving on to the next slide kind of illustrates that point slightly. So what did happen? Well, we know what did happen because hopefully the clinical records and the doctor's account will say what did happen. Then compare that with what should have happened. So what you can then do is look back at how the patient presented, compare that with objective guidance, such as guidance from NICE or from SIGN. Was the clinical management at the time, based on the presentation, based on the symptoms and signs, was it consistent with what guidelines, referral criteria, other reference sources would suggest should have happened? If you can be as objective as you can in this scenario, obviously you're somebody, if you're an investigator within a practice, this is somebody who you work with, but try and take a step back, try and give equal weight to what the complainant says and to what your staff have said, so that you can demonstrate to the person when you respond that you have done that. It adds a great deal to the weight of the response. Clinical records clearly are important here. If you have clinical records which outline all of the things that you would want them to say, that's great. If the records are missing for some reason, or if with the benefit of hindsight it could have been better, then what you want to be able to say is that, well, I didn't record X. Normally I would do Y in this situation. If I didn't in this case, I'm sorry. I will learn from this and I will document these things more fully in future. Ultimately, you can't resolve strongly held opinions about what happened without information in the record or recorded in some other way, such as a telephone call recording. What you can do in that situation is to come to a reasonable judgment based on all the information you have. And if the evidence isn't there, or if it can't be reconciled, then it's probably worth considering the possibility of holding a meeting. Disagreements, if they can't be resolved, are much more likely to result in an external review, for example, from the Ombudsman.
One of the reasons, Ed, I think it's important, particularly in Scotland, to have that independent review is the statutory duty of candour, the organisational duty of candour, the need to respond to things, which in the Scottish regulations requires somebody who's not involved in the care to consider whether or not they've tipped into starting the duty of candour, whether it's engaged by the issues that are raised. So that's one of the things that's relatively important, I think, to think about. You don't have that statutory duty yet in Northern Ireland, is that right?
We don't have the statutory duty yet. It's certainly being discussed. The statutory duty model, which is being proposed for Northern Ireland, is quite different to what's being proposed elsewhere. Yeah. The MDU has significant concerns about that, and we have made strong representations in respect of that on behalf of our members to the Department of Health and to the Department of Justice here. Whether yesterday's developments in terms of Northern Ireland will result in a new executive being established is how long is a piece of string? We'll see. But that, if the executive is established, then one of the things which appears to be on their agenda is a statutory duty of candour.
Right. No doubt more will be heard about that. So let's just think about how we could think about the clinical issues. We've reviewed your complaint as a practice, and all doctors agreed that they would have done the same as Dr. X when you attended in March. Now, that's not an unusual approach to take, that all the doctors agree that the way that it was approached was reasonable and nobody would do anything different. And in fact, we hope that is what you think, but I'm not sure this is perhaps the right way to address these issues. We've reviewed your care as a significant event to analyse whether you could have been referred under a 2-week wait rule earlier in July 2019. To do that, we've consulted the SIGN guidance or the NICE guidance on suspected bowel cancer. And this states that somebody in their 40s can be referred urgently if they have blood in their stool on testing. And when she saw you, Dr. X established that your symptoms were off, and then you go on to make it clear how that person presented by comparison to what should be done. So that's the could versus, or should versus did discussion. In terms of writing the response, just very quickly, it's appropriate to start with an appropriate introduction, an expression of empathy. Sorry, it is appropriate. If things could have been done differently, then say so. And an explanation again of how you've investigated the complaint. Explain what happened and respond to each of those points in the complaint, giving your analysis of the response of the issues, so it's clear that you're addressing all of the concerns. It's really important that you cover learning points and practice changes. This is often what people want to understand, that the practice will do things differently if faced with the same situation again, and that learning has taken place, or practice changes have taken place. When these things happen, the receptionists will do X. They will, bring things to the attention of the medical staff or the nursing staff. And in terms of the end, what the complainant can do if they remain dissatisfied, which some people will always be dissatisfied whatever you do, and where they can go. The option of meeting with the complainant should be in there, and details of the relevant ombudsman, be that the SPSO or the NIPSO. Sometimes complaints are difficult because the complainant's version of things is just factually inaccurate. That's why it's really important to get a factual account in the response from the practice, actually setting things out from the record, because you're gonna have a contemporaneous record of what actually occurred, and the patient almost certainly isn't going to have one. There may also be upsetting issues in there as well, maybe subjective comments about the practitioner, and the important thing is to respond to them professionally, not engage in catcalling or in shaming people, but just give a clear professional account of what occurred. When patients are being unreasonable, you can call them out about their behavior at the right time. You can tell them off for their behavior, you can warn them for their behavior, but it's probably not appropriate to engage with that in the complaint response itself. We often talk about separating two things out. So separate the issues in the complaint out from the behavior of the patient. Patients misbehave not infrequently, and practices have a right to defend themselves and their staff. That's completely reasonable, but it's probably not the right thing to do it in the complaint response itself. Discriminatory comments that we see them from time to time about staff members, doctors, and actually more frequently nurses, should be dealt with appropriately, but not in the letter, I would say. Ed, can you tell us about meetings? I mean, as a GP, you will have done this more frequently than I will have done it.
Yeah, so I mean, obviously, when you receive a complaint and you prepare your response, the ideal scenario is that with one letter of response, you will resolve the issues and everybody will be satisfied and the complaint disappears off into the distance. But that's not always possible. And what can happen is that the patient writes again, you write another response, and there is this ping pong with the law of ever diminishing returns applies. In that situation, I think what's often helpful is to consider the possibility of meeting with the complainant. A face-to-face meeting where things remain unresolved might be a more fruitful way of trying to resolve those outstanding issues. I mean, in terms of why, well, it is because there are issues which are unresolved, which you want to try and resolve. We then have to think about when and where a meeting might take place. And if Jared can sort of flick on the slide there, just not all of it is doing. So a meeting at a mutually convenient time. This is not a 10-minute consultation type meeting. This is a meeting usually outside of normal clinical time. Your complainant might be somebody who's trying to hold down a job themselves. So outside of normal working hours might be more appropriate, something which is mutually convenient. And certainly, as I say, a 10-minute appointment isn't sufficient. Allow enough time, but make it clear to the person who you're going to be meeting with what the time frame is, so that the meeting is not necessarily open-ended. Occasionally, it might be appropriate to try and identify a venue other than the practice, particularly if what the complainant is concerned about was particularly distressing to them and associated with that venue, namely the practice. And then also consider who else should be there. Should the patient bring a supporter of some sort with them? Who from the practice should be present? You need to have the right people there, but not too many so that the patient is outnumbered. Ideally, there'll be an independent or semi-independent chair and a separate note taker. Again, that might be a practice manager or similar. There is information on the MDU website about this. We've what I think is a very good e-learning resource. If you go to the MDU website and type local resolution meeting into the search box, there's information there which I would hope that you would find helpful.
And there's also a lot of e-learning about issues faced by doctors, other e-learning, not just local resolution meetings, so complaints with Scottish aspects to it too.
Yep. So before the meeting, I think there's a number of things which within the practice you want to try and agree. I think clearly you want to identify what issues you're going to discuss, what issues remain unresolved from the original complaint response. Try and work out roughly how long it will take to do that and to allow sufficient time, but not too much so that it's open-ended. I mentioned an appropriate venue and who might act as chair. Once you've identified the agenda points, it would be helpful to try and agree within the practice who of those who are attending the meeting will respond to each point, but also try to work out what other points might come up under any other business so that you're prepared for any curveballs that the patient might throw at you. And again, how to address those. Essentially, one of the things you want to identify is if there is any conflict within the practice about how best to respond to these points, you don't end up airing your dirty laundry in public. Try and resolve any internal conflicts before you meet with the patient. And then after the meeting, what you should do ideally is follow that up. So based on the minutes that were taken or the notes that were taken at the meeting, put that together in a letter, write to the patient. There may be a necessity to try and agree those points and agree what was discussed, and remind the patient that you've tried to respond in writing, you've held a meeting. If that has not succeeded in resolving their concerns, there remains the option of the second tier, which is the ombudsman, if they remain unhappy. And there are ombudsmen in each of the jurisdictions. So the Scottish Public Services Ombudsman is regarded as the last resort when the complainant has been through all the complaints procedure of the organisation involved. And what they do is they will look at the service provision, but also the complaints handling. And if they feel that there has been maladministration in some aspect, and if the complainant has been the victim of an injustice in their terms, they may uphold the complaint and make recommendations. My knowledge of Scotland is that this is largely something which relates to secondary care, that primary care is not overly burdened by this. I think that's probably true of primary care in Northern Ireland as well. Probably more complaints in Northern Ireland, I would suspect, do reach the Ombudsman, but it's primarily a secondary care feature. But sort of moving on to the penultimate slide. That's the last year's figures that we have available, that there were 312 health complaints related received by the Ombudsman in 2020-21. That's of many more complaints which relate to other things such as public bodies, local government, education, housing. 33% of all complaints related to health, of which about 51 referred to other health service providers, which will include primary care. What the Ombudsman doesn't say in their figures in Northern Ireland is how many of those 312 or 51 were upheld. So just if Jared wants to move on to close.
So in summary, complaints are clearly frequent. They are stressful, particularly at the moment with stretched services, and they are important because getting it right early on is likely to put the practice, the clinicians in a good place in those odd occasions that things go elsewhere. It's really important that you communicate and are able to demonstrate your communication, so you've got evidence of what you've done, that you've objectively investigated it and involved people ideally who were not clinically involved in the complaint, that you've got a structured response addressing everything, and if there is learning there, that it's been shared clearly and you can demonstrate that should there be an issue with that. You've planned for meetings and that you're clear about next steps going on if the complainant remains unhappy. Ed, one of the questions that does come up frequently, and we've got one now, is when a sorry becomes an admission of the wrongdoing. Is there anything about that? How's that done in Northern Ireland?
Northern Ireland's slightly different from the rest of the UK, whereas I mean I think in Scotland you have a specific Apologies Act, and in England and Wales there is legislation which protects the status of an apology. My understanding is that there isn't any similar legal protection for an apology. I'm aware that the Northern Ireland Ombudsman is keen for that to be enshrined in law, but I think the general principle would apply in Northern Ireland as elsewhere, which is that an apology in and of itself is not an admission of liability. It's the MDU's advice, and has been for many years, is that an apology is often a particularly effective way of dealing with and resolving a complaint. If you have any particular concerns about apologising in response to a complaint and how to frame that and how to phrase that, by all means contact us either on the advice line. The number is there on the screen now, or drop us an email to the advisory email address. We're very happy to assist with that side of things. Yeah,
it's often a concern, but you're right. There is obviously statutory protection for an apology, and of course, and actually, we don't say that doctors should always apologise. There are some circumstances when it's just not appropriate. So it's really when it is appropriate to apologise, then we'd recommend that you do so. One of the other things that comes out quite frequently is patient behaviour. So a patient, for instance, gets a warning about their behaviour and then complains about the warning, about their behaviour, and about a myriad of other things.
Yeah, I think
how do you manage that sort of behaviour? Ed, any advice on that?
Yeah, patients. My view is that the doctors and healthcare professionals in general have over the years developed particularly thick skins, and they tolerate an awful lot from their patients in many cases. But there will become a point when it is necessary to say that the patient has crossed the line, and they should be issued with some form of warning to explain that their behaviour is not appropriate, and that if it was repeated, it could result in some form of sanction. In primary care, that might include removal from the list. My advice about that in general terms is that it's a step which patients don't like and will complain about. So it's very important that the practices are transparent about their processes, that these warnings are discussed, that these discussions are minuted, so that if a complaint does go to the Ombudsman, you can show that you have had an open and transparent process. Patients should be warned where it is appropriate. They will complain. If they raise a complaint about other issues, then that complaint should probably, as you said earlier, be dealt with separately from the complaint about the warning. It's important not to conflate the two.
And of course, for doctors, the reason that we talk about this is that because doctors are vulnerable, about 2 to 3% of doctors every year are reported to the GMC. The things that are protective at the GMC are evidence of engaging with the complaint and reflecting on the issues within that complaint. The same goes for the NMC, for nurses. Evidence of having engaged with a complaint and reflected on it and changed practice if need be is protective. So getting these processes right at the practice, whilst it does seem like a bind at times and people can be unreasonable in their complaint behaviour, for that small percentage of cases that goes elsewhere, be it the SPSO, the NIPSO or the GMC, those are the cases that it's really worthwhile you as an organisation, and particularly as clinicians within that organisation, to get to reflect on what has happened and pick out any learning points that can be shared and evidenced in your appraisals going forward. If there's any questions, sorry, Ed, please carry on.
No, if a complainant is unreasonable and you act reasonably in response, then any objective third party will recognise that.
Absolutely, and the same goes for those really difficult complaints when there's an underlying health issue which impacts on how they complain, how they interact with the practice. All the people who review these complaints for the GMC, for the Ombudsman, are usually clinicians. In fact, they are for the GMC, they're always clinicians. To some extent, there are also going to be clinicians involved in a review, and they will be able to see the evidence that is provided. And if the person is unwell, their complaint behaviour is bizarre, or inappropriate, that's going to be very obvious. And if you've dealt with it all in a professional manner, that's going to be protected and make it less likely that the complaint's going to go into the next stage of the GMC processes. We always seem to end up talking about the GMC. I'm so sorry. I know it's a cause of worry for people. There aren't any other questions in the chat, so I think maybe we should just draw things to a close and let people get on with their day. Thank you so much for attending. Do look out for the other emails. We're going to have a lot of webinars coming up this year on lots of interesting and different topics, not just the core topics that we often talk about. So please do feedback to us, let us know what we might do differently, and keep a lookout for the emails for the next opportunities. Thank you very much.
Thank you very much.
Bye.